Parkinson's disease. So we're going to focus a lot on the pharmacology, but we're also going to review the basic disease. So Michael J. Fox, famous actor. Michael has had Parkinson's disease for a number of years. He has really poor movement control of his right arm. He has a progressively mask-like facial expression, and he has some abnormalities of gait. Hard to tell a lot of these when you see him on television, as they seem to have tried to hide a lot of it, but he definitely does have these things. There's Michael. You can see he really has a very mask-like face. I'm going to use a slightly different case. I'm going to talk about Mrs. Lincoln. She's older. She's in her 80s. Think of her as maybe being in a nursing home. And she has a gait in which she takes small steps and then they increase in length. This is called a festinating gait. Also, if you happen to walk next to her and you bumped into her, she would keep walking backwards. She wouldn't take a step back and then right herself. That's called retropulsion. And she's also having some difficulty with swallowing. So Parkinson's disease is an imbalance between acetylcholine and dopamine because most movement is really based on having a balance between these two things. As you know, mostly it's a deficit of the dopamine. They don't have enough dopamine, and so the acetylcholine is too high, and they develop the symptoms as described. There's atrophy in the neurons in the substantia nigra, and they just don't produce enough dopamine. So what can we do? Well, we could decrease acetylcholine, and there are medications that will do that, or we can increase the dopamine. And so that's usually what we try to do is we increase the amount of circulating dopamine. We may do that by trying to slow the metabolism. We may do that by trying to give dopamine externally, but that's usually the objective. Sometimes decreasing the acetylcholine, which is the drugs that do that are called anticholinergics, is another way to try to do that. So how could we decrease the acetylcholine? Well, we could give an anticholinergic. Procyclidine is used sometimes for people with Parkinson's disease. Mostly it's reserved for those people who are later in the disease who the dopamine-like medicines are not working anymore, but it is an option. So we could stop the breakdown of dopamine, we could give external dopamine, or we can find an agonist that isn't actually dopamine, but that is perceived as being dopamine by the receptors. So to stop the breakdown, we'll give something that interferes with the enzymes. Now we give an MAO-B inhibitor. Now MAO, when it's non-selective, is an enzyme which breaks down lots of different things, monoamine oxidase. And we find that if we inhibit it, and we inhibit it non-selectively, we help people with depression a lot. The problem with that is that people that are on MAO inhibitors really react to certain foods, aged cheeses, anything that's fermented, a number of different things. And so we don't use them much. Now, we did figure out that if we just inhibit the MAO-B enzyme, then we don't get any of those side effects. We don't get anywhere near the level of benefit from mental health issues, although we do get some, and we are using these medicines sometimes for mental health. But we get really good benefit for two things. We get benefit for Parkinson's disease, but we also get benefit for restless leg. So if you give dopamine from the outside, if you give levodopa, it crosses the blood-brain barrier and then it's converted to dopamine. The problem with that is that it is converted in the periphery and tends to cause a lot of nausea and vomiting. So how can we stop this? Well, there is another molecule that looks a lot like levodopa that basically slows down that breakdown in the periphery, but doesn't cross the blood-brain barrier, so therefore you get the full effect in the brain. So that medicine is carbidopa. So it really doesn't have any effect on Parkinson's disease, but it will dramatically decrease the side effects from the levodopa. And so the carbidopa levodopa is known as Sinemet. And again, remember that the carbidopa is really just the decreased side effects. So if you have somebody that has their Parkinson's disease progress, they really don't need any more carbidopa. They need more levodopa. And so the medicine comes in a number of different strengths. So we could also give another enzyme that breaks down the L-dopa, and that would be a COMT inhibitor. And so that's yet another option. We could also give things that look like agonists to dopamine. And so ropinirole, bromocriptine, pergolide, all of those are chemically similar to dopamine. These are even better for restless leg syndrome than any of the other Parkinson's meds. And so that's the choice usually when somebody has restless leg. So we talked about festination, we talked about retropulsion. Bradykinesia is just moving very slowly. They'll have a mask-like face. They'll often have a non-intention tremor. So an intention tremor is when you're reaching for something, you don't have a tremor, then when you reach, you get a tremor. That's usually something like benign familial tremor. A non-intention tremor is you have the tremor, you go to do something, and it actually decreases. The non-intention tremor is the hallmark of Parkinson's disease. The intention tremor is usually, as noted, associated with benign familial tremor. So they're very different tremors. Pill rolling is something that usually happens with first and lesser with second generation antipsychotics, but it definitely happens with both. And that's a thing where they basically look like they're rolling a pill in their hands. That's what that tremor looks like. So people with Parkinson's will lose dexterity and muscle control. They'll start to write small because they're really trying to focus their efforts. And then progressively it becomes harder and harder to feed themselves. And so they'll get discouraged and they'll stop feeding and they'll lose weight. They'll sometimes drool in advanced stages. In very advanced stages, they have difficulty swallowing. They'll have orthostatic hypotension. They stand up quick. They feel dizzy. Their blood pressure drops. They often have cognitive changes as well. Less than 50% get dementia, but a substantial number get dementia. And so it is one of the things to think about when someone has dementia. Notice it says apostrophe S here. That's because I'm old and I've forgotten that it was supposed to just say Parkinson. We've dropped the apostrophe S now. So other treatments, you can operate on the muscle tracts and nerve tracts. I believe Michael J. Fox had this done. There's some research going on in which they transplant fetal tissue, and that seems to have some promise, but it is not in common use currently. So thinking about this, there's lots of nursing diagnoses that you would use related to decreased nutrition, decreased mobility, impaired respiratory efforts. And again, these people lose their muscle strength and can't breathe as well. They'll also get aspiration from the dysphagia, lots of different issues. They can get urinary retention either from the actual disease or from some of the medicines that we use, and they often get constipation as well. So here's a list of medicines. I would encourage you to maybe even make up medication cards, but to be fluent with what each one of these does.